Started? Okay. Welcome back, guys. Now in yesterday's class, what we have discussed, we have started with the vascular pathology, and also we have discussed about the types of vasculitis. Okay, different types of vasculitis we have discussed. Also, we have seen about the important tumors which you need to know for your exams. That is the benign tumors as well as the intermediate risk tumors and the malignant tumors. And the malignant tumors are nothing but the cancers. We have seen the angiosarcoma. Okay, we have seen. Now in this class, okay, I will be doing some vascular topics. Vascular topic is in the sense I will be discussing about the arteriosclerosis. Okay, different types of arteriosclerosis, which includes arteriolosclerosis, Monkeyberg's medial calcific sclerosis, as well as atherosclerosis. First, we will discuss about the arteriosclerosis topic. Later, we will be discussing about small topics like aneurysms as well as aortic dissection. Important MCQs we will discuss. Later on, we will discuss the most important clinical aspects in the cardiac pathology, sir. Today itself, we are going to start with the cardiac pathology, and in the cardiac pathology, we'll be starting with the acute rheumatic fever. Okay, rheumatic fever. If possible, let's also try to do the infective endocarditis. Okay. I'm 100% sure, without any doubt, in your exams there will be a question coming from rheumatic fever. It doesn't matter whether it's FMG exam or NEET PG exam or INACT exam. One question will be there from rheumatic fever and one question will be there from infective endocarditis. No doubt in that. Okay. So we'll be doing patho as well as little integration also. These topics are going to come as clinical based questions. So we'll be doing little clinical integration also with the medicine. Okay. Having said that, now let's begin our topic. Arteriosclerosis. Now you can ask me, sir, what the hell is this arteriosclerosis? Okay, what the hell is this arteriosclerosis? In the name itself, it's a arterio means the blood vessels, okay, the arteries, and the sclerosis. What exactly is the sclerosis, sir? Sclerosis means getting hardened. The arteries are getting hardened, sir. The blood vessels are getting hardened. Arteriosclerosis. Okay, literal translation is the blood vessels are getting hardened. Now you can ask me, how many types are there and why the blood vessels are getting hardened? There are three types of arteriosclerosis. Okay, there are three types. What exactly are they? They are arteriolosclerosis. Okay, arteriolosclerosis. Arteriolosclerosis means the arterioles are getting hardened. Okay, arteriosclerosis. The second type is Monkeyberg medial calcific. Okay, medial calcific sclerosis. Okay, and the third type is atherosclerosis. See, there are three types. Okay, arteriolosclerosis, the arterioles are getting hardened, and Monkeyberg medial calcific sclerosis, the media, see in the name itself it's there, the media, the tunica media in the blood vessels. The blood vessels are made up of three layers: tunica intima, tunica media, and tunica adventitia. The tunica media is getting calcified. Because of that, the blood vessels are getting hardened. We will discuss about that. Okay, we will discuss about that. So anyway, arteriolosclerosis, Monkeyberg medial calcific sclerosis, and atherosclerosis. Okay, we will discuss about them one by one. Now, first let's begin with the arteriolosclerosis. Now, how many types of arteriolosclerosis are there? There are actually two types. Very important for your exam, hyaline arteriosclerosis and hyperplastic. Okay, so hyaline arteriosclerosis and hyperplastic arteriosclerosis. There are two types, right? Now, in which condition you will see hyaline arteriosclerosis? In which condition, sir? Such a type of hyaline arteriosclerosis, and the name itself, see, देखो, hyaline arteriolosclerosis means there is a deposition of a hyalinous pink color material. Okay, glossy pink color material is getting deposited in the blood vessel. That's actually causing the hardening of the blood vessels. Okay, so it's seen in which condition? I will show you the images also. It is seen in which condition? Hyaline arteriosclerosis is seen in benign hypertension. Okay, the patient is suffering with the benign hypertension. Hypertension is there, but it's not too much. Benign hypertension, 150, 160 mmHg range. Okay, so benign hypertension, hyaline arteriosclerosis. And then what is hyperplastic arteriosclerosis? What exactly is this hyperplasia? And is seen in which condition? hyperplastic arteriosclerosis. It is seen in malignant hypertension. Okay, malignant hypertension means severe hypertension. Hypertension more than 200 mm Hg. Okay, so more than 200 mm Hg is the systolic blood pressure. So Hyaline arteriosclerosis is seen in benign hypertension, hyperplastic arteriosclerosis is seen in malignant hypertension. Now, image based questions are very much important for your exam. देखो, this is the blood vessel, sir. Okay, this is the blood vessel. See, this is the lumen of the blood vessel. You can very clearly see the RBCs also. Okay, this is the lumen of the blood vessel. Now, look at the wall. See, there is pink color. Okay, there is pink color, sir. See, this pink color hyalinous deposition. Okay, so because of the hypertension, the blood vessels are getting hardened. Okay, they are getting resistant to encounter this hypertension, means more blood pressure is there. Okay, as there is more blood pressure, the blood vessels are also getting hardened, sir. And some amount of blood vessel injury will happen. That blood vessel injury will lead to the injury to the endothelium, will lead to deposition of this plasma proteins into the vessel wall. The plasma proteins are now going to leak. The plasma proteins are getting leaked into the vessel wall. So this pink color deposition, pink color appearance, hyalinous appearance is because of the deposition of this plasma proteins in the vessel wall. Okay, so this type is called as hyaline arteriosclerosis. I have already mentioned here, dekho, hyaline arteriosclerosis is seen in benign hypertension. Now, if you are suffering with malignant hypertension, dekho, if you are suffering with malignant hypertension, the systolic blood pressure greater than 200 mm Hg, look at the blood vessel, how it is looking like. The smooth muscles, in order to encounter such high stress, there is more blood pressure, more pressure is there. There is more and more pressure, the blood vessels can even rupture. So, to prevent this, in order to encounter such a stress, the smooth muscles in this blood vessel, now they are dividing, and what they are forming? They are forming like, onion skin kind of appearance. Okay, onion ring, onion skin kind of appearance. Okay, so that's why this is called, see, many layers are there, hyperplastic. Okay, like an onion skin. So this is called as hyperplastic arteriosclerosis, where you will be seeing the onion skinning. Okay, onion skinning. And here there will be fibrinoid necrosis also. Okay, there will be fibrinoid necrosis because the vessels are dying and pink color deposition is also happening here. Fibrinous depositions are happening. So it's an example of malignant hypertension can lead to fibrinoid necrosis. True. Okay, that's the one important point I want you to know. So anyway, just let's come back. We are discussing about what? We are discussing about the topic of arteriosclerosis. How many types? 3 types. Arteriosclerosis, Wonky-Burke's medial calcific sclerosis and atherosclerosis. Arteriosclerosis is divided into 2 types, hyaline as well as hyperplastic. Hyaline is seen in benign hypertension. Hyperplastic with onion skinning of the blood vessels is seen in malignant hypertension, where the systolic blood pressure is more than 200 mm Hg. Done, sir. Done. Next, the second type is Wonky-Burke's. Okay, Wonky-Burke's medial calcific sclerosis. Look here. So this is the blood vessel. You know it. This is the lumen. Okay, this is the lumen. Okay. Now, this layer will be tunica intima. The innermost layer is the tunica intima. What is this layer, sir? The tunica media. Okay. So this layer, which let me highlight. So this layer is a tunica media. Now, in that tunica media, are you able to appreciate this pink color deposition? So what is that? It's nothing but the calcium deposition, sir. The calcium is coming and getting deposited in the tunica media of the blood vessels. So calcification is happening. Why? So it is going to be seen in older individuals with aging. The calcium will start to come and deposit in within the blood vessels. Here also you can clearly see, sir, all this is the calcium deposition. Where the calcium is getting deposited. So the calcium, it is getting deposited within the media. So that's why the name. Wonky-Burke medial calcific sclerosis. The sclerosis is because of the calcification. Which layer is getting involved? The tunica media is getting involved. If tunica media is involved, will there be any problem for the normal lumen? Will there be any problem for the normal lumen? The normal lumen diameter is not going to be compromised. The normal lumen is going to stay normal. Okay, the lumen is going to be it's not going to be occluded. So it's not a severe condition. It's not a severe condition. So the important points which I want you to know for your exam are, so let me write. In Wonky-Burke medial calcific sclerosis, there is a dystrophic. There is a dystrophic calcification Dystrophic calcification. Even in this X-ray, you can very clearly see in X-ray, the bones are going to appear white in color. See, this is the blood vessel, sir. This is actually a blood vessel. See, in the blood vessel, okay, the calcium is getting deposited. The calcium, sir. Okay, it's not a contrast, it's the calcium which is getting deposited over there. So that's why even in the blood vessel, you are seeing this white color. The blood vessel is coming white color because the blood vessel is getting ossified. Getting calcified. The tunica media is getting calcified. So it's an example of dystrophic calcification. In the first general pathology, in general pathology topic, in the cell injury topic, I have discussed the difference between dystrophic calcification and metastatic calcification. Okay, dystrophic calcification and metastatic calcification. I'm not going to again in details about what exactly is dystrophic calcification, but here this Monkeyberg medial calcific sclerosis is an example of dystrophic calcification, sir. Seen in whom? Seen in old age people. Is it significant? This is not significant. It's a not significant, so it's not a significant condition, not a problematic thing. The way because the tunica intima is not involved, the lumen is not involved, so there won't be any occlusion. There won't be any occlusion. There won't be any thrombus formations. Okay, simple. So this is done. Now after this, now I'm showing you an image. Okay, I'm showing an image. You should tell me what exactly is happening over here. Now it's your turn. Now it's your turn. The image based question. Now what is happening? You can very clearly see, sir, the lumen, the patency of the blood vessel is getting narrowed. The lumen is getting narrowed. Here also, see, the lumen is getting narrowed. Small lumen, sir. Okay, let me put it this way. Okay, small. Why? Are we able to appreciate this lipid kind of material getting deposited over there? That's actually lipid, sir. That's a lipid core. Okay, see the lipid. See, this is the lipid deposition. Lipid is getting accumulated over there. So because of this lipid, what is happening to the patency of the blood vessel? The blood vessel is getting narrowed. And do you know what happens? Sir, this atherosclerosis, this is actually atherosclerosis, sir. The blood vessels are undergoing atherosclerosis. Now this atherosclerosis, these plaques, they will rupture. The atherosclerotic plaques, they will rupture. Whenever they rupture, platelets will start to come and accumulate in that area. Platelets will come and platelet adhesion, platelet aggregation will start to happen in that area. So forming what? See, there is a thrombus formation. Okay, thrombosis will occur, sir. So what I am trying to put into your mind, so whenever you are talking about atherosclerosis, the risk factor, the problem with atherosclerosis is there will be one day that this atherosclerotic plaque will rupture, and whenever it ruptures, it will develop. Now thrombosis will start to develop. Now the thrombus will grow and completely occludes the blood vessel. It will completely start to occlude the blood vessel, sir, leading to coronary heart diseases, unstable angina and myocardial infarction can occur. Okay, so the image, let's come from the basics. The image which you are seeing here, these blood vessels which are getting narrowed, it's all because of a problem called as atherosclerosis. Okay. Atherosclerosis. Now question to you, why? Why atherosclerosis? Any idea, guys? Buddies, any idea why exactly the atherosclerosis? Can you guys tell me any, can you guys recall any risk factors for the atherosclerosis? I will go one by one. Let's keep it as simple as possible. Lifelong, remember this. Okay, let's keep it as simple as possible. So, first, atherosclerosis, it is response. Why happens? Why atherosclerosis, sir? Why atherosclerosis? I will first listen this. It's a response to endothelial injury. It's a response to endothelial injury. Injury one time, two times? No. For example, if there is an endothelial injury which is going to happen in my blood vessel, do you think atherosclerosis will happen? No. Not one time, sir. Chronic injury. Chronic injury that is happening to the endothelial cells. Continuously there is injury. Okay, not one time, two time, continuously, chronic thing. So let me tell you why there is endothelial injury, sir. Why endothelial injury is happening? First of all, you need to know the risk factors. Risk factors for the atherosclerosis. Why a person will develop atherosclerosis? Risk factors are, let's write, smoking. Smoking, the person is taking the chemicals into his body. He is taking the carcinogens. He is taking a lot of chemicals into the body. Whenever I smoke, I am taking all these chemicals into my body. These chemicals, where they will go? They will go into the blood. So these chemicals now will start to damage the endothelium. Simple as that. These are the chemicals. See, if I start to do the smoking, I'm just inhaling the gases, the toxic gases from my lungs. These gases or these chemicals will start to go into the blood vessels. So they will start to, these chemicals will start to damage the endothelial cells. Simple. Okay. So smoking, alcohol. Okay, alcoholism, smoking, alcoholism. Next, the persons who are having hyperlipidemias. Okay, or the persons who are having infections, certain types of infections. Now this is the question, guys. Can you tell me which infections are associated with atherosclerosis? NEET PG question and INACD level questions. Which infections are associated with development of atherosclerosis? There are 3 infections which you need to know for your exam. Herpes infection. Next, chlamydia, herpes, chlamydia and cytomegalovirus infections. Next, those persons who are having obesity, diabetes mellitus and hypertension. So all these are the risk factors, sir. Smoking, alcoholism, hyperlipidemias, infections, having obesity, diabetes, hypertension. See, in all these cases, whatever I have shown you here, in all these cases, at the end of the day, there will be continuous endothelial injury. Endothelial cells are getting injured continuously. Okay. Now, not only this, there are certain other important risk factors also, like male sex, type A personality, like type A personality who are always anxious, who are always alert, like worried about everything. Okay, type A people who are like goal oriented, always they will be continuously working. Stress people, always they are taking the stress. Okay, so type A personality and old age. Next, homocystinemia. Okay, homocystinemia, it's a disease, homocystinemia. See, in all these conditions, what I have explained you, these are all the risk factors. All these risk factors at the end of the day, what they will do, sir? They will do endothelial injury. Okay, they will cause endothelial injury, sir. Now, you should know, sir, which of the following are the modifiable risk factors and which of the following are the non-modifiable risk factors? For example, which risk factors you can modify, which are under your control? Sir, smoking, you can control it. Alcoholism, modifiable. Hyperlipidemias, you can control your lipid levels. Infections, you can get protection, you can take the protection from getting these diseases. Herpes, sexually transmitted disease, like you can get the protection, you can, like it's a modifiable thing, right? And obesity, okay, obesity, you can control your BMI. Diabetes can be controlled, hypertension can be controlled. Okay, these are all the things which are under your control, sir. You can control them. Okay, risk factors. But male sex, once you are a male for lifelong. Okay, you cannot change it. You cannot change it at any point of time. So male sex, the personality, usually the personalities can also be not changed. Okay, so let me put it in a different color. So male sex, type A personality, age. The age is not under your control, and homocystinemia, this disease, okay, it's a disease which is not under your control. Once you will get it, homocystinemia, like it's a autosomal recessive disorder. By birth itself you will get it. It's not under your control. So these are the modifiable risk factors which I have shown you in the yellow color, and non-modifiable risk factors which I have shown in the pink color. At the end of the day, there will be endothelial injury. Now what exactly is atherosclerosis? Already I have explained you. It's a response to endothelial injury. Whenever the endothelium is getting injured, now there will be a response by the body. So what is that response, sir? Now that we have to study. So let's write first. What is happening? There is endothelial injury. Whenever there is endothelial injury, what happens? Now, endothelium, it's forming which layer, sir? Which layer? Intima. So intima is damaged. Intima is damaged. Simple, right? The intima, endothelium forms the intima. So the intima is getting damaged, sir. When the intima is getting damaged, guys, look here. Okay, now this is the intima, right? Intima. See, all these are the risk factors. Now, what these risk factors are doing, sir? These risk factors, they are causing damage to the intima, endothelial layer. Now, when the endothelial layer, it is damaged, now look here, sir, these cells, there are certain cells, see the platelets, these green color cells are the platelets, as well as this pink color cell, where the damaged endothelium, look, carefully look here, where the damaged endothelium, they will start to enter into the tunica media. Now they will start to enter into the tunica media. Okay, first they will come into the intima, later they will go into the tunica media. So let's write one by one. Intima is damaged. After the intima is damaged, macrophages. Come on guys, macrophages. And platelets. Where they will come, they will enter into intima. Now later what happens? So now guests came into the home. Now do you think the guests or the relatives, are they going to sit calm? No, the relatives are not going to sit calm, sir. Always they will do some nonsense, right? So even this macrophages and platelets, once they enter into the blood vessel wall, now they will start to release the growth factors. So they will release growth factors. They will start to release the growth factors. Now look here. Now these macrophages and platelets, now they are entering into the wall of the blood vessel. Now see these, what they are releasing, are you able to appreciate? See, the chemicals are being released, the small chemicals are being released because of these chemicals. Okay, these are the growth factors, sir. These are the growth factors. Now because of these chemicals, are you able to appreciate the smooth muscles? Dekho, these are the smooth muscles, this is the tunica media, right? The muscles, the smooth muscle cells, now they will start to enter into the intima. Now they will start to enter into the intima, sir. Okay, now the smooth muscles are entering into the intimal layer. Now let's write that. Release of the growth factors, smooth muscles, okay, migrate into intima. Okay, now do you think it's a normal intima now? No, this is not normal intima. Why? Because now smooth muscles entered into the intima. Now this is called as neo-intima. Okay, now there is a neo-intimal formation. Neo-intima is because of the migration of the smooth muscle cells into the intima cell. Okay, now these smooth muscle cells, what they will do? Now they have entered into the intima cell. Now what these macrophages and what these smooth muscles will do? See, endothelium is damaged, right? The endothelium is damaged. Now when endothelium is damaged, now the LDL cholesterol, the LDL molecules will also start to come and deposit here. Now LDL is also getting leaked. The LDL is also getting leaked into the vessel wall. Now, dekho, now what is happening? Sir, these macrophages, these are the macrophages, sir. And these are the smooth muscles. Okay, the smooth muscles. Now the macrophages and smooth muscles, they will start to engulf, they will start to take this LDL cholesterol. All this LDL cholesterol, whatever is getting deposited in the vessel wall, now it will be taken into the cells, the macrophages and the smooth muscle cells, they will engulf this LDL cholesterol. So next, right? What happens is the smooth muscles and the macrophages engulf what? Engulf the LDL. Okay, they will engulf the oxidized LDL, sir. Okay, now where exactly is this LDL present? Now this LDL is present inside the macrophages and inside the smooth muscles. Now these cells, now these macrophages which are loaded, with the LDL cholesterol, now such cells are called as, okay, these cells are called as foam cells. So the smooth muscles and the macrophages which are loaded with the LDL cholesterol, oxidized LDL, after taking the LDL they will do oxidation. So they are called as foam cells. Okay, so what are foam cells? Foam cells are the lipid laden macrophages. Okay, so LDL which is present in the macrophages, these macrophages are called as the foam cells. Done, sir. Now what they will start to do is, with the time the foam cells will start to accumulate, the collection of foam cells. Collection of foam cells Okay, collection of the foam cells forms the fatty streak. Now these foam cells, they will start to accumulate. Now the foam cells, many number of macrophages and many number of the smooth muscle cells, now they are starting to accumulate. Okay, they are totally filled with the cholesterol, sir. Now the collection of the foam cells forms the fatty streak. Okay, now this fatty streak is important, sir. It's the first visible or first morphological change that is seen. The first morphologically visible thing in atherosclerosis is fatty streak. So now tell me what happens. Very simple. There are certain risk factors important for your exam. What are the risk factors? Modifiable risk factors and non-modifiable risk factors. Smoking, alcoholism, diabetes, obesity, hypertension, and certain infections like herpes, chlamydia, and cytomegalovirus, and non-modifiable risk factors like male personality, male sex, type A personality, and old age, and certain conditions like homocystinemia. So this homocysteine, now it will also damage the endothelial cells. But at the end of the day, the endothelial cells are getting damaged. Now there should be a response. The body is responding. How the body is responding? Whenever there is an endothelial injury or intimal injury, now the macrophages and the platelets, they will start to get into the vessel wall. Now they are starting to enter into the tunica intima. Now after entering into the intima, now they start to release the growth factors. Now because of these growth factors, the smooth muscles which are present in the tunica media, now they will start to enter into the tunica intima, which will form neointimal formation. Now once neointima is formed, okay, now what these macrophages and what these smooth muscle cells will do? Now they start to engulf, they start to take the LDL cholesterol which is leaked into the vessel wall. Okay, because of the endothelial injury, even these cholesterol molecules, okay, not just the cholesterol, not just the LDL cholesterol, even platelets, RBC, WBC, many things will start to come into the blood vessel, but the macrophages and the smooth muscles, they will start to engulf the LDL cholesterol and they become foam cells, they become the foam cells. Now I am having one foam cell. Now many number of foam cells, they will start to accumulate and forms a fatty streak. Now see, the cholesterol core, the lipid cholesterol core is going to form, sir, because of this accumulation of many number of foam cells. So within the vessel wall, these foam cells are accumulating and forms at the end of the day atherosclerosis. Done. Okay. So what are the important points which you need to know in your exam? Earliest visible lesion. The questions that can come in your exam is earliest visible lesion. The earliest visible lesion is fatty streak. What exactly is fatty streak? It's a collection of the foam cells. Okay. Now you can ask me, sir, atherosclerosis, where exactly it's going to occur? What's the most common site? Most common site of atherosclerosis. Any idea, guys? What is the most common site of atherosclerosis? There is a mnemonic. Okay, ACP, sir. The most common site is ACP, means abdominal aorta. Okay, abdominal aorta. C for coronary arteries. Most of the students will think coronary arteries are the most common site of atherosclerosis. No, it's the abdominal aorta. Okay, I will show you the image also. So coronary arteries followed by popliteal artery. Okay, so abdominal aorta, coronary arteries and popliteal arteries, this is the order, sir. This is the order of atherosclerosis. So what is the most common blood vessel that is affected? Abdominal aorta is most commonly affected in the atherosclerosis. Next, what is the least common site of atherosclerosis? Okay, atherosclerosis can occur in any blood vessel. What is the least common site? Most common site is abdominal aorta. Okay, what is the least common site? The least common site is circle of Willis in the brain. Okay, circle of Willis in the brain cell. Next, complications. So if there is atherosclerosis, okay, so what are the complications? I have explained you. Atherosclerosis, this is atherosclerotic plaque. It will rupture one day. It will grow, and one day it will rupture, sir. Totally the intima totally is going to be ruptured. Okay. Now when it is ruptured, what happens? Platelets will start to come and accumulate over there and forms a thrombosis. Okay. So rupture. Complication is rupture. Today or tomorrow it will rupture. Whenever it is ruptured, that will form thrombus. We form the thrombus. The thrombus can lead to first angina and myocardial infarction. Okay, myocardial infarction, coronary artery disease. Coronary artery disease or myocardial infarction. Now, that blood vessel which is having atherosclerosis, may develop aneurysms. Okay, aneurysms, and that blood vessel may develop dissection. Okay, dissection, sir. Okay, the blood vessel wall, the wall of the blood vessel might tear up into two parts. Okay, two parts. There is a possibility. So, what are the complications? The complications are rupture, aneurysmal formation, and dissection. These are the three complications which you need to know for your exam. Now, look here, guys. What exactly is this? So, here this is the descending aorta, right? You know it. This is a descending aorta. Sorry, let me put it this way. I shouldn't say descending aorta. So, this is abdominal aorta. Okay. First ascending aorta, arch of aorta, descending aorta in the thorax. Now once it is entering into the abdomen, it is abdominal aorta. So now this is abdominal aorta. Now at the L1 segment, you know it, the renal arteries are arising. Okay, these are the renal arteries going for the kidneys. Now down to the renal arteries. Okay, down to the renal arteries. So are you able to appreciate here what happened? So this part of abdominal aorta have developed the atherosclerosis, and here you can also see the aneurysm, the dilation. The blood vessel is that abdominal aorta is totally dilated. Why? Because of the atherosclerosis. So this is the most common site of atherosclerosis. You know, abdominal aorta is the most common site of atherosclerosis, but where? See, this is also abdominal aorta. Where exactly in the abdominal aorta? Below the renal arteries. Below the renal arteries. See, guys, can you tell me what is this area? The abdominal aorta is dividing. The abdominal aorta is bifurcating into iliac arteries. Okay, common iliac arteries. So this is the site, this is the most common site of atherosclerosis. Okay, here also we can very clearly see. So here there is bifurcation. This is the place where bifurcation is happening. Okay, into the common iliac arteries. Now, this is the abdominal aorta. Okay, you can go through this explanation. If you want to go, you can take a screenshot and you can go through this explanation. The same thing. Okay, the most common site, let me write here. Most common site in abdominal aorta. It is below the renal arteries and above the iliac, below the renal arteries, below the renal arteries and above iliac, the common iliac arteries. Okay, before the bifurcation of the common iliac arteries. So with this, the topic of atherosclerosis is completed. Okay, all the important points, whatever you need to know for your exam, it's completed, sir. Image based questions. Okay, usually atherosclerosis is something associated with. Here also you can see there is a dilation of the blood vessel because of the atherosclerosis. Clearly look here, there is atherosclerosis in the blood vessel, sir. Okay, there is atherosclerosis there. Okay, now after this, let's talk about a small topic, a simple topic, which is called as aneurysms. So what exactly are these aneurysms, sir? Any idea? Guys, do you have any idea what exactly are the aneurysms? Come on, now we'll start to take your questions. Guys, can you tell me what exactly are the aneurysms? One more. Localized abnormal dilation. See, let me, just not the dilation. See, even for example, if I take nitroglycerin, okay, if I take nitroglycerin, that will also cause dilation, sir. Okay, that will also cause a dilation. It's a irreversible dilation. Okay, you should say one more. It's a irreversible dilation of the blood vessels. Okay, of course you said abnormal. Yeah, you should say, sir, there is irreversible or permanent dilation of the blood vessels. Irreversible or permanent dilation of blood vessels. Permanent dilation of the blood vessels. Okay, dilation of blood vessels or even heart. Okay, now questions that will come in your exams are how many types of aneurysms are there? How many types? There are three types of aneurysm, simple. There are three types. What are they? What are the three types of aneurysms, sir? The three types of aneurysms are true aneurysms. Second types are pseudo aneurysms. And third type are mycotic aneurysms. Okay, there are three types of aneurysms. Just give me 1 minute. Okay, so there are three types of aneurysms which I want you to know. True aneurysms, pseudo aneurysms and mycotic aneurysms. Three types of aneurysms. Now you can ask me, what exactly is a true aneurysm, sir? Dekho, now here this is a normal blood vessel. You know there are three layers in the normal blood vessel, sir. Tunica intima, tunica media, tunica adventitia. Three layers. Now here you can clearly see, so the blood vessel is dilated. Now in this dilation process, see all the three layers are involved. Okay, all the three layers are involved. As all three layers are involved, it is called as a true aneurysm. It's called as a true aneurysm. Okay, here also dekho, sir, in this dilation process, all the three vessel layers are involved. If all the three vessel layers are involved, then it is called as a true aneurysm. Okay, true aneurysm. Okay, it can be on one side or it can be on both sides. That's a different thing. That's a different thing. But what is a true aneurysm? Right? All three layers are involved. Okay, all three layers are involved, sir. Then what exactly is a pseudo aneurysm? Then in pseudo aneurysm or false aneurysm, okay, pseudo aneurysm or false aneurysm, they go here. See, there is a damage. Okay, they go here. There is a damage to the blood vessel. There is some trauma. There is damage to the blood vessel. Now, see, the blood is coming out like this, and it's forming a hematoma, sir. Now it is forming a hematoma. Okay, so here is the extravascular connective tissue. That's the extravascular connective tissue. Now the blood is forming a hematoma. Now if you look it from outside, if you are looking it from outside, it's just looking like the blood vessel is dilated. It's not just that blood vessel is dilated, sir. It's the damage which happened to the blood vessels leading to the hematoma formation. There is a hematoma. Clot is there within the blood vessel. Okay, so externally it looks like a dilation. So these are false aneurysms. These are not the aneurysms. These are the pseudo aneurysms. Okay, so pseudo aneurysms are due to hematomas. They are because of the hematomas. They are seen in the hematomas. Now last but important, mycotic aneurysms. So can you guys tell me what exactly are these mycotic aneurysms? Mycotic aneurysms, what exactly are they? Mycotic aneurysms are because of what? Any idea? Mycotic aneurysms? Just 1 minute, guys. Need to take a charge. Okay. So mycotic aneurysms. Come on. Monish is giving big answers. Okay. Good. Yes. But we just want the simple short answers, but I appreciate your your effort in typing so much things. But anyway, guys, can you tell me what exactly are mycotic aneurysms? They are seen in infections, infections. Okay, see, the name is saying mycotic. Mycotic here, it doesn't mean because of some fungus. Mycotic, you know, mycology means study of fungus. But here it's not because of the fungus, sir. It's because of some bacteria. Which bacteria? Staph aureus. Okay, so when you are having infection to the blood vessels, that even causes the aneurysms. So dilation of a blood vessels seen in infections are called as mycotic aneurysms. Mycotic aneurysms are most commonly because of which organism? Most commonly because of Staph aureus. And what is the most common blood vessel that is involved? The most common blood vessel that is associated with the mycotic aneurysms are femoral artery. Okay, associated is a femoral artery, sir, important. Okay, femoral artery. Now, apart from this, true aneurysm, pseudo aneurysm and mycotic aneurysm, I want you to know a little high yielding thing. There is one more aneurysm which is called as Iotic aneurysm. Okay, Iotic aneurysm, sir. Okay, bacteria, not the fungus, bacteria. Okay, so Iotic aneurysm. So, Iotic aneurysms are seen in which conditions? So, Iotic aneurysms are associated, they are seen in a condition called as syphilis. Okay, tertiary syphilis. Okay. Now, this is the image based question, very important image based question. So you can clearly see here the aortic root, the aorta, the starting part of the aortic root is getting dilated. Okay, the aortic root is dilated, sir. Even the entire aorta is affected. If you look at the aorta, sir, now the aorta, it's looking like a tree bark, the bark of the tree, you know the bark of the tree, right? How it looks. So, these lutic aneurysms are seen in which condition? Tertiary syphilis. Okay, so how these syphilitic aneurysms, how these syphilitic aneurysms are going to appear? See, there will be tree barking appearance. Tree barking appearance. There will be tree barking appearance. Now, one more important point I want you to know is, so because of this aortic root dilation, you just think logically and tell me, so the aortic root, the aorta, it's getting dilated, aneurysm, aortic aneurysm, the aortic root is getting dilated. When the aortic root, when it is getting dilated, what happened to the aortic valves? So near the aortic root only, no aortic valves will be there, the leaflets, the aortic valve leaflets. Now these aortic valve leaflets are also going to go away from each other, moving away from each other. So what will happen? There will be aortic regurgitation. Blood will enter into the aorta and again the blood will come down. The blood will come down, fall back into the left ventricle. So in this condition, the patient is going to have, note, the patient is going to have in this aortic root dilation, the aneurysms which are seen in tertiary syphilis, there will be aortic regurgitation. Okay, aortic regurgitation. Okay. So blood will fall back again into the left ventricle, sir. So that's the one thing which I want you to know. Syphilitic aneurysms are seen in tertiary syphilis. Syphilis is because of which organism? Treponema pallidum, the spirochete. Okay. So whenever you are having infection, okay, whenever you have specifically infection with this organism, okay, what happens is, I don't want to go in detail, there will be something called as obliterative end arteritis, that will cause aortic root dilation and tree barking appearance. Enough. Okay. So after this, what else you should know? The next topic which we have to discuss for the exam is this one. Yes, can you tell me what exactly is happening here? They go. Now this is aorta, you know it, right? This is the aorta, sir. Okay, aorta. Now there is a damage to the vessel wall. Now the blood is entering into the vessel wall. So the jet of blood is going to enter into the vessel wall, and the vessel wall is going to split into two parts. There is a splitting. Okay, there is splitting. So here also you can very clearly see there is damage. The blood is entering. Now the blood is flowing where? The blood is flowing through the vessel wall, and this blood is again coming back into the lumen. With again there is one more damage here. Again the blood is again coming back. Okay, coming back, sir. So this is what? This is aortic dissection. So here this is the real image, the gross image. You can see the blood is in the wall. Okay, done. Now what you need to know for your exam? Aortic dissection. Now, right, jet of blood. What is happening? Jet of blood flow through the vessel wall. Okay, flowing through the tunica. Where? Flowing through the tunica media. Vessel wall means in the tunica media. Now, question, sir, what are the most common causes? Sir? Why aortic dissection? Okay, what are the causes of aortic dissection? The most common cause of aortic dissection, MCQ, in your exam is hypertension. If there is hypertension, the vessel wall will be damaged, and this blood will start to enter into the tunica media. So that's the hypertension, sir. And other causes includes, we have seen, even in the topics of genetics, we have discussed about Marfan syndrome. The autosomal dominant disorder. The most common cause of death in Marfan syndrome is aortic dissection. In Marfan syndrome, connective tissue disorder, the fibrillin, okay, the fibrillin protein is the fibrillin protein is defective. Okay, the fibrillin protein is going to be defective. Connective tissue disorder, there is weak connective tissue. So the connective tissue and the blood vessels are also very weak. So they will be easily damaged. The blood will start to enter into the vessel wall. So Marfan syndrome, That's the one cause. In Marfan syndrome, what happens? There is cystic, right? This is important. Cystic medial necrosis. There is something called as a cystic medial necrosis of the vessel wall. The vessel walls are very weak. The connective tissue in the vessel wall is weak now. So there will be cystic medial necrosis that will lead to aortic dissection. Now, if you are having aortic dissection, for example, say, if I am the person right now, if I am having aortic dissection, what will be the classical clinical feature? Guys, can you tell me? Clinical feature. If I am having right now aortic dissection, what kind of clinical feature that I am going to have? Guys, can you tell me? Bojraj, yes, good evening. Good evening. So the clinical features are going to be sharp pain. Where? In between the scapula. Okay, there will be very sharp pain, very sharp, severe pain in the mid-scapular region. Okay, there is a sharp pain in the mid-scapular region, sir. That's the one important point I want you to know. Okay, so you can very clearly see here. So this is the true lumen. See, there is a true lumen, and here is a false lumen, sir. The blood vessel wall, it is getting split into two parts. There is a false lumen, and it is a true lumen. Now you can, just by looking at this, you can understand what's the problem with aortic dissection. Because of this aortic dissection, the normal lumen patency, the patency of the lumen is going to be narrowed. Okay, so look here also. See, this is the false lumen now. See, the blood is there here in the false lumen. So this here also same. The blood is going through the false lumen. So that the original lumen, the true lumen is going to be totally obliterated. Okay, so that will actually kill. It's a medical emergency, sir. It will actually kill the patient. Okay, so done. So aortic dissection topic is also completed. Now after this, let's start with the cardiac pathology. Okay, in the cardiac pathology, let me tell you what are the important topics that we are going to discuss. So in the cardiac pathology, first we will start with the rheumatic fever. Okay, very important for your exam. Next you should know infective endocarditis. After that you should know about the different types of vegetations. Next we have to discuss about the coronary artery diseases, like what is stable angina, unstable angina, and next we have to discuss about myocardial infarction. After myocardial infarction, what are the changes you will see in the labs? What are the changes you will see? What are the ECG changes? Okay, what is ST elevated MI? What is non-ST elevated MI, STEMI and non-STEMI? We have to discuss. After that, we also have to go through the cardiomyopathies. Okay, cardiomyopathies, hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy. Also, we have to discuss about cardiac tamponade. Okay, what is cardiac tamponade and constrictive pericarditis. So these are the important topics that we are going to discuss in the cardiac pathology. Now, having said that, let's, without any further late, now immediately start the topic of rheumatic fever. Okay, rheumatic fever. Let's begin with the rheumatic fever. See, now many students will have a confusion. So what is rheumatic fever and rheumatic heart disease? Are they one and the same? First itself I am telling you, see, first the person is going to get the rheumatic fever. In this rheumatic fever, if there is heart involvement, if the heart is involved, then it is called as rheumatic heart disease. So first rheumatic fever plus heart involvement is rheumatic heart disease, sir. Okay, you will understand it one by one. So now let's begin with the rheumatic fever. Next, and rheumatic heart disease. First we will discuss about rheumatic fever and rheumatic heart disease. Now my question to you, who will get the rheumatic fever, you and me? Will we get the rheumatic fever? Usually no, sir. Usually the possibility is going to be very less. Usually rheumatic fever, very much important for FMG exam, it is seen in between these years, 10 to 15 years. Okay, in some books mention 5 to 15 years. Rheumatic fever is something seen before 15 years, sir. Before 15 years, 5 to 15 years or 10 to 15 years, both are true. Depends on the book. Both are true, sir. Most commonly, it is going to be seen in female children. Okay, female children. It's an example of type 2 hypersensitivity reaction. Okay, it's an example of what? It is an example of type 2 hypersensitivity reaction. We will go one by one in detail. We will discuss. First, general points I am telling you. Acute rheumatic fever is seen in females. True. Acute rheumatic fever. What the hell is this, sir? What the hell is this? See, this is an autoimmune disease. Okay, autoimmune disease. You know, all autoimmune diseases are coming under type 2 hypersensitivity reactions. Autoimmune diseases are most commonly seen in females. Okay, which females? Children, sir. Children are going to be affected. Okay. Now, why there is this autoimmunity? Let me tell you in a simple way. First, let's look at here. Now, imagine there is this one child. So this is the gold child, happy child. Okay, such a small child of, for example, 10 years. Okay, 10 years, female, sir. Now this 10-year female, now she got an infection in her throat. Okay, now she got an infection in her throat, sir. Throat infection. That is what? Pharyngitis. Okay, pharyngitis. Now, this pharyngitis is because of which organism? It's because of gas, group A, Streptococcus. There is an organism called as group A beta hemolytic Streptococcus. Okay, because of this group A beta hemolytic Streptococci, now this female is having pharyngitis because of this group A beta hemolytic Streptococci. Now she is having pharyngitis, throat pain. Now tell me, her immune system is going to be activated or not? Yes, her immune system is activated, sir. Now this is the bacteria, right? Now this is the bacteria. Okay, now the bad guys, sir. This is the bacteria. Now look here, this bacteria in its cell wall, okay, it's having a protein, sir. It's having a protein. This protein is like an antigen. Now it's acting like an antigen. Of course, bacterial things are antigens. Bacterial cell membrane components are the antigens. Okay. Now this protein name is called as M protein. Okay, M protein, sir. Now, see, the point here which I want you to know is, sir, this girl's immune system is getting activated. Now, the antibodies are getting produced, sir. The antibodies, now they will start to go and attack this bacteria. Okay, the M protein. But what happens is here, the antibodies which are produced against the bacteria, now these antibodies will start to attack. Okay, this is not why, this is the antibody. Okay, antibodies will start to attack own tissues. Own tissues, sir. So why, you can ask me why? Why? Because see, this M protein, which whatever is there, the M protein which is present in the bacteria, this M protein, the M protein resembles N-acetyl glucosamine. Okay, the N-acetyl glucosamine, sir. In our body, in our every damn cell, okay, in our every damn cell, there is this N-acetyl glucosamine present. N-acetyl glucosamine is present in our own body. Now, this N-acetyl glucosamine and the M protein, they are having the similar structure. They are having the same structure. So, these antibodies are confused. Our immune system is confused. So, the antibodies which are produced against the M protein, yes, of course, they will attack the bacteria, no doubt. But they will also start to attack my own heart because N-acetyl glucosamine is present in my heart. These antibodies will start to attack my brain because N-acetyl glucosamine is present in my brain. It will start to attack the skin, start to attack the joints. Okay, now this antibodies will go and start to deposit in the joints, leading to the joint pain, heart involvement, skin involvement, okay, and brain involvement. Okay, so this is the concept, sir. So here the main problem here is molecular mimicry. Okay, there is molecular mimicry. So who is doing this molecular mimicry? M protein. The M protein resembles N-acetyl glucosamine. Okay, done. My question to you. See, imagine you are a child. Imagine you are a child of 15 years or 10 years. Now you got group A beta hemolytic streptococcal pharyngitis. You got the pharyngitis. So, are you going to develop this rheumatic fever? Are you going to develop this rheumatic fever? No, not everyone. Just 3% of the population. Just 3% of the population. 3% of the individuals, unlucky fellows. 3% of the fellows who are living in poor, unhygienic conditions in underdeveloped countries. Okay, those fellows will develop rheumatic fever, acute rheumatic fever. Okay, acute rheumatic fever. Okay, if 100 individuals, they are getting the group A beta hemolytic streptococcal pharyngitis. Out of 100, 3 people will develop rheumatic fever. Okay, so now let's see one by one important points. Dekho, highlight. So it's an autoimmune inflammatory disease. Autoimmune disease I have explained you. Caused by what? Caused by group A, that is beta B, that is group A beta hemolytic streptococci. Which strains? There are different strains. Okay, strain number 1, 3, 5, 6, 18. 1, 3, 5, 6, 18. These are the important strains of group A beta hemolytic streptococci which can lead to rheumatic fever. See, sir, it occurs only secondary to sore throat or pharyngitis. Okay, streptococcal sore throat or streptococcal pharyngitis. See, even you can get the streptococcal skin infection, sir, which is called as impetigo, streptococcal infection to the skin. So, this streptococcal skin infection or this impetigo will not cause rheumatic fever. It is a streptococcal pharyngitis can lead to rheumatic fever. Okay, that's important MCQ. I have explained you only 3% of the cases will develop the rheumatic fever or rheumatic heart disease. I should say rheumatic fever, sir, mainly rheumatic fever. Okay, rheumatic fever. Okay, only 3% of the cases with this pharyngitis can develop the rheumatic fever first. Now, what is the pathogenesis? Explained to you the pathogenesis is molecular mimicry or the cross reactivity. Antibodies are mistakenly attacking the N-acetyl glucosamine. So, the target here is the N-acetyl glucosamine. Okay, so M protein resembles which antigen in the body? N-acetyl glucosamine. Okay, so done. Now, these antibodies will also start to attack the heart, leading to carditis, heart involvement. If the heart is involved, I have explained, if the heart is involved, then it is called as rheumatic heart disease, rheumatic heart disease. So, what is that cardiac involvement? See, the one question, now itself I am telling you repeatedly in your exam, this is the question that will come. In just general FMG exam, in FMG exams, they will ask you, what is the most common valve affected in rheumatic heart disease? Mitral valve, sir. This is the question which was asked, I think, almost 5-6 times. Most common valve involved in rheumatic fever is mitral valve. Which valve is not affected? Sir, which valve is not affected? Pulmonic valve. Okay, pulmonic valve is almost not affected, sir. Okay, least affected. Okay, so done. Having said that, shall we begin the topic? Now, look here. Okay, let me put it this way. Now, imagine I am the one who is having rheumatic fever first. Okay, let me say something like this. Imagine I am the one who is having rheumatic fever. Okay, how can you put the diagnosis that, sir, you are having rheumatic fever? How can you put that the diagnosis, the rheumatic fever? How can we keep the diagnosis? See, the diagnosis is done with the help of a criteria called as Jones criteria. Okay, so the criteria name is called as the Jones criteria, sir. So Jones here stands for J for, sir, if I am developing rheumatic fever, my joints will be affected, sir. Okay, antibodies will start to attack the joints, leading to arthritis. So joint involvement. O, write it like a heart symbol. Okay, like a heart symbol, sir. O for heart involvement. And N for nodules. Which nodules? Under the skin, you will start to see the subcutaneous nodules. I will show you. Okay, subcutaneous nodules. And E stands for erythema marginatum. On the skin, you are going to see the rash, which is called as the erythema marginatum. Erythema is going to be seen, especially in the margins. I will show you the image, which is called as the erythema marginatum. And S stands for Sydenham's chorea, nervous system involvement. Sydenham's chorea, sir. Okay, nervous system antibodies will start to go and attack the basal ganglia region, leading to the Sydenham's chorea. Okay, JONES. What I am trying to put into your mind is, sir, if I am the person who is having rheumatic fever, okay, rheumatic fever, what is the criteria used to put the diagnosis? Jones criteria. Okay, modified Jones criteria. Sir, according to the Jones criteria, what are included in rheumatic fever? JONES, joint involvement, heart involvement, nervous system involvement, erythema marginatum, okay, erythema marginatum, subcutaneous nodules, and Sydenham's chorea, sir. Okay, now we will come one by one, sir, one by one. The most important thing is heart involvement. Okay, the heart involvement. So, inflammation of the heart. The antibodies will start to attack the heart, leading to the inflammation, carditis. So, which carditis, sir? Endocarditis, myocarditis, or pericarditis? Which carditis is going to be seen? Now, look here. Let's begin with the pancreatitis. Okay, the entire heart will be affected, not just one layer. Entire heart will be affected, sir. So, there will be pancreatitis. In rheumatic fever, if the heart is involved, then it is called as rheumatic heart disease. Okay. Which part of the heart is affected? Endocardium, myocardium, or pericardium? Entire heart is affected. All three layers can be affected. Okay. So, pancreatitis. First, let's begin with the pericarditis. First, let's start with the pericarditis. I am starting with pericarditis. See, if pericardium is involved, okay, which type of pericarditis it will cause? Later in tomorrow's class, we will discuss about different types of pericarditis also. There are serous pericarditis, hemorrhagic pericarditis, fibrinous pericarditis, different types of pericarditis is there. Now look here, this is the pericardium, sir. How it is looking like, dekho. How it is looking like? It's looking like very cheesy butter kind of appearance, right? So this is called as bread and butter appearance of the pericardium, sir. Bread and butter pericarditis. Okay, fibrinous pericarditis are bread and butter pericarditis. Pericardium is affected. How the pericardium is looking like? It's looking like a bread and butter. So it is bread and butter pericarditis, a type, okay, a type of fibrinous pericarditis. Okay, so now imagine a child is coming to you. Imagine this is the child coming to you with a rheumatic heart disease. Now, which part of the heart will be affected? Sir, all three layers can be affected. Endocardium, myocardium, pericardium can be affected. Okay. See, one more thing you should remember. Don't think every time there will be pancarditis. See, any layer can be affected, sir. Any layer can be affected. Endocardium, myocardium, or pericardium can be affected. If there is pericardial involvement, now what you will hear, the patient is having inflammation in the heart, right? Very pain will be there, and this boy is crying. When you try to auscultate, what you will hear is pericardial friction rub or auscultation. Okay, MCQ. On auscultation, there will be pericardial friction rub. And whenever the boy is continuously crying, and whenever you go for the ECG, okay, whenever you do the ECG, now there is ST segment elevation, okay, there is ST segment elevation, sir. Now you are just thinking, right, you might be a little confused, sir. Usually first year students and second year students, they will know only till here. ST segment elevation is seen in myocardial infarction. See, not only in myocardial infarction, even ST segment elevation is seen in pericarditis. Pericarditis will show ST segment elevation, sir. Okay, so especially it is called as a concave. Okay, concave ST segment elevation. They will use the word concave. ST segment elevation. Okay, ST segment elevation. How it's going to be concave ST segment elevation. Okay. It's going to be seen something like this. There will be a concavity. Okay, there will be concavity, sir. So concave ST segment elevation is going to be seen. Okay. Apart from that, we have seen concave ST segment elevation as well as pericardial friction rub. And how we have to treat this condition? So pericarditis is treated by giving simply steroids. Steroids are enough. Steroids are enough. Going to treat the inflammation. Steroids are anti-inflammatory. Yes, they will decrease the pericarditis. Now, there can be myocarditis, myocardial involvement. Okay, the myocardium of the heart can be involved. If the myocardium is involved, then it is called as a myocarditis. Okay, true. Now, that can lead to, if the myocardium is involved, so the muscle is getting involved. The muscle is going to become weakened. That will cause heart failure, sir. Congestive heart failure. The myocarditis can actually kill the patient, sir. Okay, so acute congestive heart failure, the heart is failing. If the heart is failing, if the heart is not pumping properly, what will happen? Now the blood will start to accumulate back. Now there is no forward blood flow. So the blood is starting to accumulate in the lungs, which will cause pulmonary edema. Okay, Okay, so this myocarditis, how we have to treat, sir. This boy is going to present to the clinic with the symptoms of acute pulmonary edema. Okay, you can hear the crackles, bilateral crackles are going to be seen. Okay, so how we have to treat this? We have to treat this by giving LMNOP. What is LMNOP? So you have to decrease this edema, pulmonary edema, by giving the drug called as Lasix. Okay, Lasix, sir. Okay, M for morphine, we have to decrease the pain. Lasix, morphine, nitrates, you have to give the nitrates, oxygen therapy, and even the positioning. Okay, P4 positioning, you will study this better in your internal medicine in your 4th year and 5th year. Whenever you are going to the internal medicine, then you will study better about them. LMNOP stands for Lasix, you have to give Lasix, morphine, nitrates. Okay, why nitrates? Nitrates are going to decrease the preload. Nitrates are the vasodilators. They will decrease the preload to the heart. Okay, and oxygen, you have to give the oxygen to the person, to this boy, and positioning. Okay, you have to not in the supine position. You have to make the position little upward. Okay, not in a supine position, sir, so that the venous return decreases, right? So what we are discussing about the carditis. There will be pancarditis. Pancarditis includes pericarditis. How to treat the pericarditis? Simply by giving the steroids. How we can know that the patient is having, how we can know that the boy is having pericarditis is by doing Auscultation, there will be pericardial frictional rub. Okay, there will be frictional rupture because the pericardium is inflamed. And there will be ST segment elevation, concave ST segment elevation. Treatment is done by steroids. And myocarditis is treated by giving drugs, LMNOP. And endocarditis, from here important. For pathology, this is important, sir. Endocarditis. Sir, inside the heart, the endocardium, your heart valves, the mitral valve, aortic valve. Okay, so the mitral valve, tricuspid valve, pulmonic valve, aortic valve, they are all made up of what? They are all made up of the endocardium. Endocardium, sir. Endocardium is forming these valves, heart valves. So, in endocarditis, there will be valvulitis. Okay, valves are going to be affected. If the valves are affected, there will be stenosis or regurgitation, mitral stenosis, mitral regurgitation can happen. Okay, we will discuss one by one. We will discuss one by one. Dekho, sir, endocarditis is there. I have explained you. What is the most common valve affected? Mitral valve is affected, sir. Okay, see why mitral valve is affected. There is a very big, reason why mitral valve is affected. We no need to go in that much detail why mitral valve is affected. Why? Because mitral valve is present on the left side. On the left side, high pressures are going to be there. There is a big story, sir, for that. Now, in pathology, what you should know is there will be pancarditis. Endocardial involvement will be there, leading to endocarditis. In endocarditis, valves will be affected. The heart valves will be affected. The most common valve that is affected is mitral valve, and the least common valve that is affected is a pulmonic valve. Okay, done. So, least commonly affected valve is pulmonic valve, done. Now, initially, Dekho, from here, the story is little important, sir, little interesting. Now, imagine for the first time I am having rheumatic heart disease. First time I am getting the pharyngitis. Now, in this pharyngitis, after the pharyngitis, I am an unlucky fellow, the 3% of the population. I have developed the rheumatic fever. Now, in this rheumatic fever, now my heart is also getting involved. Okay, not only joints, not only skin, not only central nervous system, my heart is also getting involved. So, now I am having acute rheumatic heart disease, sir. Now, first time if I am having rheumatic heart disease, first time, there will be endocarditis, okay. So, initially, I will be having mitral regurgitation. Mitral valve is affected. What is the problem with the mitral valve? Mitral regurgitation. The mitral valves are not closing properly. They are not closing properly. So, there will be mitral regurgitation. The blood from the left ventricle is going into left atria. Left ventricle say the blood is regurgitating back into the left atria, sir. So, mitral regurgitation is seen in children, sir, initially. But second time, again I got the pharyngitis infection. Imagine I am living in a poor hygienic environment in slum kind of area. Again I will be getting pharyngitis. Whenever I get pharyngitis again antibody production, again heart is getting attacked. Third time, fourth time, with more number of infections, more number of heart involvements, more number of times the heart is getting affected, more number of times the endocarditis, more the number of times the mitral valve is getting affected. Initially there will be regurgitation. Regurgitation will heal, right? First the mitral valve is getting affected. It will heal. First time healing, second time healing, third time healing. So this healing at the end of the day with more number of attacks, there will be mitral stenosis. More the number of attacks, there will be mitral stenosis, sir. So that's why in adults, okay, whenever this boy, whenever he become the adult, because of the more number of attacks, he might develop mitral stenosis. Okay, so mitral regurgitation is seen initially, followed by mitral stenosis. What is the difference between them? More the number of attacks. Initially, mitral regurgitation followed by mitral stenosis. Now, dekho here. See, this is the mitral valve. Okay, mitral valve. How it is looking like? Sir, this mitral valve, it is looking like a fish mouth. So, there is fish mouth stenosis in rheumatic heart disease. What kind of mitral stenosis is seen? Sir, the mitral stenosis is going to look like a fish mouth. So, it is called as a fish mouth stenosis. Simple. Fish mouth stenosis. Okay. Next, done. I have explained to you. Sir, the patient, initially what he is going to have? Sir, the mitral valves are involved. Okay, the mitral valves are involved. Mitral regurgitation is there. There is a jet of blood. Dekho. There is a jet of blood that is getting regurgitated into the left atria. A jet of blood is getting regurgitated into the left atria. Now, see, in this left atrial wall, because of this regurgitated jet of blood in the left atria, are you able to see this white patch kind of appearance? So, continuously with every heartbeat, from the left ventricle, the blood is getting ejected into the left atria, sir. Now, this jet of blood is striking the left atria. left atrial posterior wall. So that is causing this patch kind of appearance or the plaque kind of appearance, which is called as a Meckelum's plaque. Okay, so what is this Meckelum's plaque? Where it is seen? Seen in left atrial posterior wall. Because of what? Because of mitral regurgitation. Because of the mitral regurgitation, the regurgitant jet of blood is striking the left atrial wall, causing this plaque, Meckelum's plaque. Okay, so this is also completed. Fish mouth stenosis completed. Meckelum's plaque is also completed. The question that was asked in one of the FMG exams and NEET PG exams is Meckelum's plaque is seen in which chamber? It is seen in left atria. Seen as a complication of what? Seen as a complication of mitral regurgitation. Okay, in acute phase, in acute rheumatic heart disease, you will see mitral regurgitation. In chronic rheumatic heart disease, many number of times there will be mitral stenosis. How the stenosis is going to look like? Fish mouth stenosis. Done, sir. Next, what else you should know regarding the endocarditis? Dekho here. Sir, these are the heart valves. Okay, this is the mitral wall which is affected, sir. The mitral wall is affected. Valvulitis. Right? Valvulitis. Now my question to you is, see, the mitral valve is inflamed. Mitral valve is affected. Endocarditis, inflammation of the mitral valve. Now these mitral valves, they are beating, sir. They are closing, right? They are closing. Continuously they are beating and they are closing. So there will be damage to the mitral valve. Mitral valves are going to be damaged or not? Damaged, sir. Whenever there is a damage, their platelets will start to come and deposit in that area. Okay, platelets will come and start to deposit in that area, forming what? Forming thrombosis, or I should say small thrombus, which are nothing but called as the vegetations. So here, are you able to appreciate this small vegetations? So these are the vegetations, sir. Okay, now where you will see these vegetations? In the mitral wall. The vegetations are going to be seen along the line of closure. Okay, that's the exact place. For example, imagine, see, these are the two mitral valves, two mitral valve leaflets. Now wherever they will close, see, these areas are getting damaged because of the inflammation. Okay, now along the line of closure, you will see these vegetations, MCQ. Okay, the vegetations are seen along the line of closure. My question to you, sir, this rheumatic heart disease, the heart is getting affected. Is it because of the bacteria? No, the heart is not getting affected because of the bacteria. The heart is getting affected because of the antibodies. The antibodies are attacking the heart, not the bacteria, sir. So these vegetations are nothing but the platelet accumulations. Okay, so they are sterile in nature. There is no bacteria. The vegetations which are seen in rheumatic heart disease, they are going to be seen along the line of closure, and these vegetations are sterile in nature. Done. So one more important MCQ completed. Where the vegetations are seen along the line of closure. Again MCQ point. There is fish mouth stenosis of the mitral wall. Now next, what else? Now because the walls are getting affected, endocarditis, mitral regurgitation. Whenever there is mitral regurgitation, the blood is going from the left ventricle into the left atria. Will there be abnormal sound or not? Yes, sir, there will be abnormal sound. Definitely there will be abnormal sound. So there is going to be mid-diastolic murmur, sir. Just wait. See, let me put it this way. No, this is not, you should say auscultation when you do. Okay, when you do auscultation. See, when the left ventricle is contracting, okay, when the left ventricle is contracting, the blood have to go into the aorta. But now when the left ventricle is contracting, means systole, during systole, when the left ventricle is contracting, because of the weak mitral walls, because of the inflamed mitral walls, there will be mitral regurgitation. So there will be systolic murmur. Okay, there will be systolic murmur. Mitral regurgitation is going to have, it is going to cause pan-systolic murmur. Okay, there will be pan-systolic murmur, sir. Okay, that's the one thing which I want you to know. Now next, other important point, one is pan-systolic murmur is heard. Okay, in mitral regurgitation, pan-systolic murmur is heard, sir. Okay, well and good. Now there is something called as flow murmur. In this rheumatic heart disease, even flow murmur is heard, sir. What exactly is this flow murmur? The flow murmur is also called as a Kerry-Coombs murmur. Okay, Kerry-Coombs murmur. What exactly is this is? Simple. Try to understand like this. Put it this way. Sir, when heart is contracting, now some blood have ejected into the left atria, extra blood have gone into the left atria. Now this extra blood whatever have gone into the left atria, now again this extra blood will come down, right? Okay, this extra blood, now it will flow down. Okay, it will flow down during the diastole, whatever the extra blood goes up, now this extra blood, it is going to flow back again into the left ventricle. So this extra blood coming down into the left ventricle will also cause a little sound, sir. So that is called as a Carey-Coombs murmur. So Carey-Coombs murmur is a flow murmur because of the flow of that extra blood from the left atria into the left ventricle. Put it this way in a simple way, try to understand it like that, and it's seen during diastole. Okay, so it's a mid diastolic murmur. Okay, so there is pansystolic murmur, true, because of the mitral regurgitation, and because of the backflow of blood there is also Carey-Coombs murmur, which is a mid diastolic murmur. Mid diastolic murmur, sir. In many of the exams this question was asked. Carey-Coombs murmur is seen in rheumatic heart disease. It is a systolic murmur or diastolic murmur? It's a diastolic murmur, sir. It's a mid diastolic murmur. That's the best option. Okay, so what have we have seen? Heart involvement. Just as a recap. Okay, just as a recap, guys. Come on. Any doubt? Yeah, okay. Now let's put it this way. So heart involvement is going to be pancreatitis. So pericardial involvement will be there, bread and butter pericarditis, which is the example of fibrinous pericarditis. There will be pericardial friction rub going to be seen. Yes, sir, excellent. Pericardial frictional rub, and there will be ST segment elevation, concave ST segment elevation treated with steroids. Done. And there will be myocarditis, which can actually kill the patient because of the congestive heart failure. And how can you treat this myocarditis? With the LMNOP. Okay, Lasix, morphine, oxygen, positioning, and nitrates. And very important for the students is endocarditis. Endocardial involvement, the valvular involvement. Which valve is going to be most commonly infected? Not infected, inflamed. The mitral valve. Mitral valve. Initially there will be mitral regurgitation. With more number of attacks, there will be mitral stenosis. So acute phase, mitral regurgitation. In chronic phases, there will be mitral stenosis. What kind of stenosis? Fish mouth stenosis of the mitral valve. Because of the mitral regurgitation, what you will have? McClump's plaque. Okay, this McClump's plaque is seen in the McClump's plaque, sir. It is seen in the left atria posterior wall, left atrial posterior wall, because of the mitral regurgitation. Okay, done. And what else, sir? So there will be damage to the mitral wall, leaflets. So at the line of closure, at the exact line of closure, you are going to see the vegetations. Sir, these vegetations are small. They are sterile vegetation. They are not septic vegetation. They are sterile vegetations which are seen along the line of closure. These vegetations are made up of what? Mainly they are made up of the platelets. The vegetations are mainly made up of the platelets, sir. Even other components are there. I will explain you. Vegetations are made up of what? Platelets, not the bacteria. Okay. Now, other MCQs which I want you to know is, sir, heart is getting involved. Okay. Myocardium is getting involved. Okay. Now, if you look, imagine the patient is dead, sir. Imagine, unfortunately, this boy, a 10-year-old boy, is dead. Now, when you do the biopsy, what you will see? Sir? So, in the heart, you can see something like this. Okay, dekho. So, this is the heart. In the myocardium especially, you can see here. So, there is a granuloma. Inflammation, sir. It's actually granuloma, sir. What exactly you are looking here? See, there are lymphocytes, histiocytes. See, this granulomatous inflammation, the granuloma, which is seen in the myocardium, this granuloma is called as ash of body, MCQ. This is called as the ash of body, sir. The ash of body, what exactly is it? Sir, ash of bodies are nothing but the granulomas. These are the areas of fibrinoid necrosis. These are the areas of granulomas and fibrinoid necrosis with, let me put it this way. Okay, so we will be having ash of bodies. Okay, ash of bodies. It's a morphological examination. The patient is dead. So whenever you do autopsy and look here, so the ash of bodies are seen. These are the pathognomic MCQ. The pathognomic for the rheumatic heart disease is ash of bodies. So what exactly are these ash of bodies? The ash of bodies are nothing but a granulomas. It's a collection of what? It's a collection of lymphocytes, plasma cells, swollen collagen fibers, and histiocytes. Histiocytes are nothing but the macrophages, right? Histiocytes are nothing but the macrophages. Okay, so the area of the ash of body is nothing but a granuloma. It's a granuloma. Okay, so they will ask you in your exam, sir, ash of bodies, in the area of ash of bodies, which type of necrosis is there? Fibrinoid necrosis. Again MCQ. Okay, this is a very important MCQ. Astral bodies are pathognomic for rheumatic heart disease. Now, if you look here, sir, this macrophages, this histiocytes. Okay, I am showing you one histiocyte, sir, from this area. Okay, let's take one histiocyte. Dekho, here is one histiocyte. Okay, now this histiocytes, whenever you look how it is looking. The nucleus is looking like a ribbon. Okay, the nucleus is looking like a ribbon, sir. So these are ribbon shaped macrophages. Okay, ribbon shaped nucleus is present in these macrophages. Okay, so these cells are called as Aneurysm cells. Okay, this they also say like, they are looking like a caterpillar or ribbon shape. Okay, there are multiple terminology that is used. So it's a caterpillar like nucleus. The caterpillar like nucleus. So these macrophages are called as Aneurysm cells. So Aneurysm cells are seen in rheumatic heart disease. Okay, they are seen in rheumatic heart disease, but even they are seen in normal myocardium also. But most of the time in your exam they will ask you Aneurysm cells are seen in which disease? Which disease? Rheumatic heart disease. What are these Aneurysm cells? They are ribbon shaped nucleus in the macrophages. Ribbon shaped macrophages are called as Aneurysm cells. Aneurysm cells are seen in Astral bodies. Okay, Astral bodies. Astral bodies are example of Astral bodies. Okay, they are examples of fibrinoid necrosis. They are pathognomic of rheumatic heart disease. Okay, so done. Cardiac involvement is completed. Okay, now I have said you what is the criteria? What is the criteria to establish that this baby is suffering with rheumatic heart disease? You know, the criteria is Jones, Jones. Out of Jones, what we have completed? O. Heart involvement completed. This is a major thing, sir. 75% is the heart involvement only. Others are very simple. Now, dekho. So, diagnosis. Let's put it. Let's go in a one by one order. So, diagnosis is made with Device-Jones criteria. According to this Device-Jones criteria, okay. Same. At least if you want to say, this fellow is having rheumatic fever. At least the patient should have first the history of group A heat streptococcal infection. Okay, the mother should say, yes sir, my child have suffered with group A beta hemolytic. She should say that he suffered with pharyngitis 3 weeks back or 4 weeks back or 1 month back. Okay, he suffered with pharyngitis 1 month back, sir. Okay, so there should be an evidence, there should be a history of group A beta hemolytic streptococcal infection. Along with this, the person should have two major criteria. Okay, along with the history of group A beta hemolytic streptococcal infection, the patient should have two major criteria. There are 5 major criteria. You know, JONES. There are 5 major criteria. Out of these 5, at least 2 major criteria should be present. Okay, 2 major criteria should be present. Or at least 1 major criteria should be there, along with 2 minor criteria. You don't know what are the minor criteria. Later I will explain you what are the minor criteria. Now, how to put the diagnosis that the patient is having rheumatic fever? Evidence of or history of group A beta hemolytic streptococcal pharyngitis, along with at least 2 major criteria or 1 major criteria with 2 minor criteria. You know the major criteria, JONES, out of which we have completed the heart involvement, carditis is completed. Now, let's see other major criteria. So, okay, now let's begin with the other major criteria, sir. So, the second major criteria that I am going to discuss is a migratory polyarthritis. Okay, migratory polyarthritis. What is this word, sir? Migratory. Say, the antibodies now will start to attack the joints also. First, my elbow joint will be affected. First, after 3-4 days, first my shoulder joint will be affected, followed by my elbow joint is affected, my wrist joint is affected, my hip joints, my ankle joint, my knee joints. So, there will be joint involvement. First, for example, my shoulder joint is affected. Now it is resolved, sir. Now, okay, the pain is reduced, the inflammation is reduced. After 3-4 days, my elbow joint is affected. After 3-4 days, it is reduced, everything is become normal. After that, my wrist joint is affected. So, there is a migration. So, migration of the inflammation from joint to joints. And that to which joints are getting affected? Large joints are not the small joints. Okay, this is not rheumatoid arthritis. Rheumatoid arthritis is different. This is rheumatic arthritis. Rheumatoid is different. Rheumatoid means the proximal interphalangeal joints, distal interphalangeal joints are involved. Now I am talking about the large joint involvement, that too migratory. Okay, so first, right, most commonly the large joints are going to be affected. Out of JONES, the earliest one to appear is this migratory polyarthritis. Okay, just within 2 weeks. Now I have developed the streptococcal pharyngitis. Within 2 weeks, I can develop this migratory polyarthritis. Okay, it's the earliest to appear, sir. I have told you that there won't be any problem. Yes, inflammation is there, it's going to be reduced. After that, one more joint involvement. So there is no deformity in the joint. There is no residual deformity. Okay, but in rheumatoid arthritis, that is different. That you will study in your rheumatology, sir. Okay, again that's also autoimmune disease, but there is deformity in the joint. Joints will become something like this, deformity in the joint. But here there is no such thing. So no residual deformity. Okay, let me put it this way, guys. Remember JONES. What are these? These are the major criteria: joint involvement, heart involvement, JO, right? Heart involvement, subcutaneous nodules, erythema marginatum, synonym scoria. All these are the major criteria. Now, please listen with both your ears. Sir, joint involvement. What is a joint? Migratory polyarthritis, right? Migratory polyarthritis. See, in India, where the cases of rheumatic fever are more common, okay, even monoarthritis, not migratory polyarthritis, not the migratory polyarthritis, sir. Just monoarthritis is enough. It can be taken as a major criteria. No need to wait till multiple joint involvement. Just even if one joint is involved, you can consider it as a major criteria. So in high endemic areas like India, monoarthritis is enough to consider it as a major criteria, sir. Okay, so again and again I'm telling you, this is not going to be a big problem. It will be resolved. Okay, it's a non-erosive arthritis. No deformities are going to be seen, non-erosive arthritis. But if the boy is having pain, if the boy or the girl, if they are suffering with the pain, if they are crying, you can give the non-steroidal anti-inflammatory drugs like aspirin or naproxen. Done. Simple aspirin, naproxen is enough. Done. Okay. Next, what are the important points? Migratory polyarthritis, multiple joint involvement, large joints are involved, no residual deformity, non-erosive arthritis, no deformity. First symptom to appear is the migratory polyarthritis. In endemic regions, in high endemic regions like India, no need to wait till migratory polyarthritis, just monoarthritis can be taken as a major criteria. Done, sir. Treatment is done with aspirin. Next, synonym scoria. Okay, synonym scoria, sir. So J completed, O completed, joint involvement, pancarditis, cardiac involvement is also completed. Now let's talk about the synonym scoria. See, what is synonym scoria? Okay, it's a late manifestation, sir. Seen after 3 months, 3 to 6 months, sir. Some books even mention 6 months. So if today I get the streptococcal pharyngitis, to develop the synonym scoria, how much time I should wait? 3 months. So by this time the mother have actually forgotten that after 3 months who will remember that the child is whether having pharyngitis or not. Okay, it's a very late manifestation, sir. The late manifestation. So it's seen after 3 months. So what exactly is happening here? There will be involvement of the basal ganglia. The basal ganglia structures are going to be affected. So that there is involuntary, rapid purposeless fast movements. Okay, involuntary rapid purposeless fast movements. So the boy, he is sitting and he is doing all these abnormal movements. The mother or the others, the school teachers might be thinking this boy is a naughty boy. He is doing all these unnecessary purposeless movements. Okay, but he is not doing it voluntarily. It is happening by automatic, involuntary. So because of this, he will be having poor handwriting. Okay, in the clinical question they can mention the boy is having poor handwriting. Because of this, he cannot have a proper grip. Okay, the basal ganglia structures, the motor structures are affected, sir. So he cannot write properly. There will be involuntary movements leading to bad school grades. Okay, bad school grades. Okay, he will be doing, like, whenever you do examination, if you ask the boy to show his tongue, okay, he will be doing a snake-like movement, darting tongue, sir. Okay, the snake, how it will do, how it will take its tongue, okay, like that. I don't want to show. So it's a darting tongue. Okay, darting tongue will be seen. Okay, it's a like purposeless movement of the tongue, darting tongue. And if you ask if you ask this boy to have a grip, now give your finger to this boy and ask to have a grip. Now I can have a very tight grip, right? So this boy, because of the involvement of the motor structures, he cannot have a proper grip, very weak grip. So which is called as a milkmaid. Milkmaid grip is going to be seen. MCQ. Milkmaid grip, darting tongue, poor school grades with unnecessary purposeless movements in a child who had a recent history of pharyngitis. Think about rheumatic fever. Think about rheumatic fever. Okay, so his reflexes are going to be decreased. Okay, and that too, let me tell you, sir, migratory polyarthritis, simple condition, not a big problem, not a big problem. In the same way, even the syndromes chorea, it will also be self-resolving, sir, within 6 to 12 months, self-resolving. Okay, it will automatically resolve. No need to worry about this. Okay, but if the mother is worried, because of this unnecessary purposeless movements, okay, the mother is worried, then you can give drugs like valproate, okay, haloperidol, phenobarbital, the CNS depressants, they decreases the activity, sir. So valproate, haloperidol and phenobarbital can be used to treat the syndromes chorea. But even after 6 months, the chorea is not coming down. Whatever the drugs you are giving, the chorea is not coming down, it's continuing. So medically refractory chorea, sir. Okay, if everything fails, it's a medically refractory chorea. Okay, so then what you have to do, then the option is going to be IVIGs, intravenous immunoglobulins, MCQ. So for medically refractory chorea, you have to give intravenous immunoglobulins, but generally for treating chorea, you can use valproate, phenobarbital and haloperidol. So this is also completed, sir. Now, very important MCQ. First manifestation to occur is a migratory polyarthritis. The second the last manifestation to occur is syndromes chorea, sir. Last manifestation. So one is after 2 weeks, other is after 3 months. So do you think both these clinical features are going to be present at the same time? No. By the time syndromes chorea develops, this arthritis is already resolved, sir. Okay, so arthritis and chorea cannot coexist at a time. Why? Because arthritis is the earliest manifestation and chorea is the late manifestation. They are not going to be seen together. Okay, so JO and S are completed. Now what we are left with? Subcutaneous nodules, simple, sir, and erythema marginatum, one single slide. See, you can have development of this subcutaneous nodular development, especially in the extensor region. Okay, especially in the extensor sites, is going to be seen. Okay, so subcutaneous nodules seen in extensor surfaces, and erythema marginatum, you can have, see, the boy is having a rash. Okay, and the rash also, see, look, the margins are having the erythema, so that's why erythema marginatum, sir. Okay, this is not a ringworm. Okay, so this is erythema marginatum, right? So usually the erythema marginatum is not going to be very well appreciated in the Indians because we are having a more darker skins. Okay, in the fair skin people, it will be very much appreciated. Usually in the Indian population, it's not well clearly seen. Okay, not clearly seen. So geographically, red macular lesions. Okay, will be central white color with the margins which are erythematous. Okay, so done. So completed, sir. All JONES are completed. So J for migratory polyarthritis, O for pancreatitis, N for subcutaneous nodules on the extensor surfaces, E for erythema marginatum, the margins are going to be erythematous, and last S for syndromes chorea, sir. Okay, so all JONES are completed. Out of this major criteria, to put the diagnosis, to say that this boy is having, rheumatic fever, at least you need to have 2 major criteria. Okay, that's what I am telling you from the beginning. So you need to have a history of group A beta hemolytic streptococcal infection, at least with 2 major criteria out of this JONES, or 1 major with 2 minor criteria. Now you will get it out. Sir, we know the major criteria, 5 major criteria we know. Then what is the minor criteria, sir? What are the minor criteria? There are 5 minor criteria, sir. Okay, 5 minor criteria. What are they? Simple. Look here, diagnosis. We are discussing about the minor criteria now. What are the 5 minor criteria? Say, if this baby is having polyarthralgia, not arthritis, just not inflammation, just pain in the joints, polyarthralgia. Okay, and fever. Okay, if the boy is having polyarthralgia or fever or elevated erythrocyte sedimentation rate. Okay, CRP levels, acute phase reactants, CRP levels are elevated, and prolonged PR interval in the ECG. Okay, prolonged PR interval in the ECG. Okay, in the ECG, you know, right? See, this is P wave, QRS, P wave. So this is the PR interval. Okay, this is the PR interval, sir. So this PR interval time, if it is prolonged more than 0.2 seconds, okay, it should be less than 0. Normally it is 0.1 seconds, sir. If it is more than 0.2 seconds, if it is more than 0.2 seconds, then it is called as a prolonged PR interval. Okay, in medicine you will study why there is prolongation of the PR interval, because of the Aschoff nodules. Okay, Aschoff nodules deposited in the conduction pathway. The Aschoff nodules will start to deposit in the conduction pathway. So PR interval is going to be prolonged. More time. Okay, but I don't want you to know all this, like, you know, minor details. Simple, sir. What are the minor criteria? There are 5 minor criteria. What are they? Polyarthralgias, fever, elevated erythrocyte segmentation rate, elevated C-reactive protein levels, and prolongation of the PR interval. If you have any of them, you can consider it as a minor criteria. So, okay, what are the major criteria? JONES. Minor criteria: polyarthralgias, elevated erythrocyte segmentation rate, CRP levels are elevated. Next, the prolongation of the PR interval and fever. So these are the 5 minor criteria. So done, sir. So major criteria completed, minor criteria completed. Okay. So now what are the most common cause of death? The most common cause of death in acute rheumatic heart disease is endocarditis. In chronic rheumatic heart disease is myocarditis. Overall, most common cause of death is myocarditis. Myocarditis, I have explained you. It will cause congestive heart failure and it can kill the patient. It can kill the patient, sir. Okay. So done. Now what we are more worried about? Just tell me what we are more worried about as a doctor. Say we are more worried about that first time a child came to you. Now he is fulfilling the Jones criteria. Okay, revised Jones criteria. He is fulfilling. He is having two major criteria are there. That's it. A history of streptococcal pharyngitis and 2 major criteria are there. So done. Now you can say, okay, this boy is having rheumatic fever and rheumatic heart disease. If heart involvement is there, rheumatic heart disease. Done. Now what you are more worried about? Initially he will be having mitral regurgitation, sir. But in the future, if this boy who is living in a unhygienic area, in a slum area, in future if he again gets streptococcal pharyngitis, again he will develop the cross reactivity, molecular mimicry, again heart will be affected, again carditis. So more the number of attacks, he will develop the mitral stenosis that can actually kill the patient, worse thing. So we are worried about the future infections. So how we have to prevent the future infections? Okay, see, now what we have to give to this patient is IV benzathine penicillin, sir. Okay, so we have to give IV benzathine penicillin intramuscularly for every 3 weeks. Means this fellow, for every 3 weeks he should come to the hospital. Lifelong he have to come, sir. Lifelong he have to come to the hospital for once every 3 weeks, and he have to take IV benzathine penicillin. Why? Because this is unlucky fellow, 3% of the population. If in the future if he gets one more attack, he will develop mitral stenosis. So IV benzathine penicillin intramuscularly for 3 weeks. Why? This is a prophylaxis to prevent future sore throats. That is prophylaxis. For how much time you have to give? Lifelong treatment is ideal. But practically this is not possible, right? Okay, 10-year-old. Okay, till he's, for example, if he's living for 90 years, for the next 80 years coming to the hospital and taking, it's not practical thing. Okay, so in the questions, see, the patient is having heart involvement, rheumatic heart disease. Heart disease is there. Heart is affected, but also valves are affected. Mitral valve is also affected. Not just pericarditis or not just myocarditis. Endocarditis, valvular involvement is there. Okay, rheumatic heart disease with valvular lesion. So at least for 40 years you have to take the IV benzathine penicillin. Sorry, not IV, IM benzathine penicillin. Okay, for 40 years he have to take that. In a question if they are mentioning, sir, rheumatic heart disease there, heart involved, but not the valves, not the endocarditis, maybe myocarditis or pericarditis, that's it. So rheumatic heart disease without the valvular lesion. If there is no valvular involvement, you have to continue the prophylaxis for 21 years at least. Okay, 21 years is the best answer, sir. Okay, always lifelong treatment is best. If there is an option lifelong, go for the lifelong option. If you don't find that, if valvular involvement, if valvular lesion is there, 40 years. If there is no valvular lesion, at least for 21 years. Or if they mention, simple, rheumatic fever. They are not saying whether the heart involvement is there or not, simple, rheumatic fever, sir. how much time you have to take the prophylaxis. Okay, so 21 years, sir. If heart involvement is not there, then 21 years. If heart is not involved, 21 years. Heart is involved and the valves are involved, 40 years. Okay, heart and valves both are involved. Heart and valves in the sense, if the valvular involvement is a rheumatic heart disease with the valvular involvement, 40 years. Only heart involved, 21 years. Rheumatic fever, 21 years, that's it. Okay, so these are the important points which I want you to know. You know, already you have discussed, sir, arthritis, migratory polyarthritis. What we have given? Sir, migratory polyarthritis, aspirin, naproxen. Okay, aspirin, naproxen, non-steroidal anti-inflammatory drugs. Sir, pericarditis, we have given steroids. For chorea, we have given haloperidol, valproate, phenobarbital, we have discussed. For medically refractory chorea, what we have given? Intravenous immunoglobulins. Done, sir. For prophylaxis, what we have to give? IV, sir, not IV, IM benzathine penicillin for 3 weeks, lifelong. Okay. In one of the exams, this question was asked. Imagine I am the child, sir. Okay, I came to you, I am a 10 years old child. Imagine I am the 10 years old child who came to you. Now, right now I am having rheumatic heart disease. Okay, rheumatic heart disease, sir, my heart is affected. Now, what you have to give? You have to prevent the future attacks. Sir. So, what you have to give? IM benzathine penicillin, lifelong you have to give me. Okay, or at least 41 years, at least 40 years you have to give me. Now, what if I am allergic to penicillin? I am the boy who is allergic to the penicillin, sir. Okay, imagine I am the 10-year-old boy who is allergic to penicillin. So, you are not supposed to give penicillin. If you give penicillin, that will cause anaphylaxis and that can actually kill me. So, in this condition, what you have to give for prophylaxis? It's a macrolide, sir, azithromycin. Okay, in a patient who is having penicillin allergy, then the next alternative which you can use is the azithromycin. Okay, azithromycin. Okay, so with this, rheumatic fever and rheumatic heart disease, all important points are also completed. Okay, now this will be enough for today. In tomorrow's class, let's discuss about the infective endocarditis. Okay, and let's also discuss about the myocardial infarction and cardiomyopathies in tomorrow's class. Okay, hope the class is helpful. Guys, is the class helpful? I have integrated as much as possible. I have integrated, sir. Is that okay? So shall we meet tomorrow? Guys, we'll meet tomorrow. Today it's completed. Goodbye, guys. Bye-bye.